All right. The meeting of the Health Professions Subcommittee will come to order now. Can we call the roll?
Senator Saslaw,
Here.
Senator Newman, Senator Edwards, Senator Lewis,
Here.
Senator Dunavant,
Here.
Senator Suterline,
Yes.
Senator Pillion, Senator Barker.
Here.
You have a chair. You have a quorum, Mr. Chair.
All right. It's Friday. So. All right, Senator Morrison, you're up first. So.
Thank you, Mr. Chairman. Senate Bill 772. Somebody just pointed out to me, boy, does the world look different in medical cannabis than it did in 2016 when we, I think, probably overregulated a little bit in an abundance of caution to try to put a lot of checks and balances in. And as you'll remember, we created a situation where a physician could write a recommendation for medical cannabis, and it would go to the Board of Pharmacy for registration. And with COVID and with the sudden increase in the numbers and the difficulty in coming up with employees to process all this, fell way behind in terms of the number of permits that were able to be granted to people. And at the same time, marijuana in small amounts has become legal. So why are we going through all of this this kind of falderall? And so what this bill does with the new line amendment is basically take that requirement away from the Board of Pharmacy to do that permitting process. And you can just proceed with the form that they've created through another bill that transferred it from the Supreme Court to the Board of Pharmacy to create the form that doctors will use, and that bill's already gone through. But it also, what the bill does is it deletes the notion that that the Board of Pharmacy has to regulate what a 90-day supply looks like for a patient. That should be with the pharmacist to determine that based on needs. This is language that I came up with that I believe has been placed also into Senator Dunavant's bill, and so that's what it does. It basically dials back some regulatory requirements that were in the code that just made it really difficult, and it's really hard for people to register for medical cannabis, and this will unjam the backup.
What's different in the substitute from the introduced?
Well, I think if I could bring up folks here, it is mostly the part of it is the not having the requirement that the pharmacy board deal with the 90-day supply. Are there any other?
Mr. Chairman, I think our bills are alike. I don't know if we're going to hear them separately. I think Senator Marsden wants us to go ahead as it is. Okay, very good.
Yeah.
And Mr. Chairman, members of the subcommittee, Hunter Jamerson, representing Jushi. We've worked closely with Senator Marsden on this bill and very much appreciate him bringing it. The line amendment he's referencing, the introduced bill in lines 261 through 264, included a provision that would require the Board of Pharmacy to regulate what constitutes a 90-day supply. And without speaking for the Board of Pharmacy, in my discussions with the Board of Pharmacy, I understand from a technical matter that's impractical because the board doesn't have sufficient information about the patient's need or the prescriber's judgment to dictate what constitutes a 90-day supply. So the amended bill leaves that 90-day supply determination to the certifying practitioner and the dispensing pharmacist.
All right.
Thanks.
All right. Any other questions from the members of the subcommittee?
If I could just say one thing, this is going to be great for the processor's business to be able to free up people being able to get to them and get the products that their physician feels are appropriate for them and the pharmacist feels is appropriate for them, and it takes a tremendous burden off the Board of Pharmacy.
All right. Anyone wish to testify in favor of the bill?
Chairman Hunter Jamerson. I'll be brief as I think you know where I stand, but I would say that this bill is going to be great for the patients because there are patients who are waiting 4.5 months in some instances to receive their certifications. There are hospice patients who are waiting for, their registrations in a time of desperate need. This bill solves a very important problem, and the Board of Pharmacy is trying to manage this program with the skeleton crew. And after last year's flower expansion, I think registration requests proliferated. As a result, this bill is desperately needed, solves the problem, and I think will result in a lot less phone calls to your offices.
I created this bottleneck. I'd like to get rid of it.
Mr. Chairman, members of the committee, Randy Pearson on behalf of Columbia Care, the licensed medical cannabis processor, or HSA 5. We support the bill and echo the comments of Mr. Jamerson. Thank you.
All right, thank you.
Good morning, Mr. Chair and members of the committee. Cassidy Crockett-Burba on behalf of the National Organization for the Reform of Marijuana Laws. We support the bill and thank the Senator for introducing the bill and offer our full support. This will bring much-needed improvements for Virginia's 40,000 medical cannabis patients. Thank you.
Good morning. Missy Wessolowski with Greenleaf Medical. We support the bill.
All right.
Sarah Payne from Jushi Inc. With the Delizzo pharmaceutical processor permit. We thank the committee for their consideration and especially Senator Marsden for his support of the program. And just on behalf of all our patients, some of whom have waited as much as 6 months for their registration card, and some of whom have passed away waiting for the registration card, thank you so much for considering this bill.
Thank you. All right, is there anyone who wants to testify in opposition?
Dave, what exactly is this? I got here. What are you doing?
All right. The bill is before the subcommittee.
Recommend report as amended.
Yeah. We didn't adopt the amendment, I don't think, did we? No. I don't think, yeah, substitute.
Substitute,
yes.
move the substitute.
All right. It's been moved that we adopt the substitute. Is there a second?
Second.
All right. All in favor, say aye.
Aye.
All opposed, no. All right, that substitute's before us. Senator Donovan.
Move to recommend report as substituted.
All right.
Second.
All right.
Second.
Yeah, we have a motion and a second, so we'll vote on it now. Call the roll.
Senator Saslaw, Senator Lewis,
Aye.
Senator Donovan,
Aye.
Senator Suderline,
Yes.
Senator Pillion, Senator Barker,
Aye.
6 ayes, no 0.
All right. Thank you. Your
Thank
bill's
you so much.
recommended for reporting. Senator Pillion, I think, has to go down to another committee here shortly, so. And, yeah. Huh? Yes.
Exactly. I actually have two, but I'll be glad to wait, or if you want me to go ahead, I'll be glad to.
Go ahead. Go ahead and present this, so.
Rehab, which is marijuana right now. So, sorry. What's that? You don't need me. Okay. So the first one is Senate Bill 590, and this deals with the dental faculty workforce issue that we're facing in the Commonwealth. So the bill amends and reenacts the Code of Virginia, which the 54.1-2713, which regulates the license to teach dentistry. This amendment will help with the clinical shortage. The proposed amendment allows graduates of foreign dental programs to obtain a limited faculty license to teach dentistry in Virginia if they meet the credentialing standards of the dental school, which is the same thing that we do for medicine. Dentists granted this license will be able to perform all patient care and research activities associated with teaching dentistry. However, this license would not allow the individuals to count this time toward obtaining a regular dental license in Virginia, which was a concern of the VDA,
Right.
nor would allow faculty licensee to practice dentistry outside the dental school. So we've worked with VCU and the Dental Association to come up with language that was appropriate for both. And I think there's some people to speak in favor. And
Yes, Senator Donovan.
Is this done in other medical education programs?
this is done for the medical school as well.
It has been for a while.
And has been for a long time and been a successful program.
All right. Any other questions, Senator Suderline?
much as I love hearing about people that like Senator Pillion's bills,
Hey, come on, Dave.
speak in opposition, could we?
People here that want to speak because they can't.
Yeah, they can.
Let's go through the process here and make sure, I don't want to tell anybody that came
Yeah.
to speak.
We're with
that
you. They're in
me.
white.
All right, we'll take.
I'm sure Dr. Russell wouldn't mind.
Anyone in support of the bill, come forward, so.
Here we go. He's always here.
He likes me. He likes me.
Senator Barker, members of the committee, we had the opportunity to work with on this bill technically, and the administration supports this bill.
All right.
Senator, members of the committee.
Certainly.
I'm Dr. Al Russell. I'm the department chair of restorative dentistry, prosthodontics, and hygiene at the School of Dentistry. Our problem, and I'll try to be brief, is getting qualified faculty. Other states have this amendment in their bill, and I can't compete with them. When people come and ask, when they look at our advertisements, can they get a faculty license? When I tell them no, they go to North Carolina, they go to New York, they go to Ohio. So in brief, this aligns us with the medical community and other states so we can, provide you with a quality dental school here in the Commonwealth. Thank you.
All right, anybody else to speak in favor?
Just say the Virginia Dental Association.
All right. Thank you. Anyone want to speak in opposition to the bill? All right, the bill's before us.
Move to recommend report.
Second.
All right, with motion and a second to recommend reporting. If there's no further discussion, call the roll.
Senator Saslaw. Senator Lewis. Senator Genevant.
Aye.
Senator Suderline.
Yes.
Senator Pillion.
Aye.
Senator Barker.
Aye.
Ayes 6, noes 0.
All right, and you have one more.
I do. Mr. Chairman, Senate Bill 594 comes from DMAS and DBHDS. It's a cleanup bill from the legislation I sponsored in 2018, and it helps strengthen the code so that Medicaid members can't be charged for prescriptions for opioids for pain management or for prescriptions for medications for opioid use disorder, regardless if the prescriber is in the Medicaid network or not. This is to target the cash clinics that help fuel the opioid epidemic, which is still a problem and has unfortunately reared its ugly head during the pandemic.
Right.
The current law provides a loophole for non-Medicaid providers to charge cash as long as they notify the members they have an option to go to a Medicaid provider. The General Assembly funds the ARTS program, which is a very successful program for Medicaid members to get quality treatment. And we want to make sure that they're utilizing the ARTS program rather than providers that don't have the best track record for quality care.
All right, any questions from the committee, subcommittee? All right, anybody want to speak in favor of this bill?
Ma'am, we're going to have to ask you to sit down and speak into the mic so the public can hear you.
Good morning. Becky
Morning.
Bowers-Lanier, and I'm with the Virginia Association of Community Services Boards, and we are very much in support of this bill.
All right, thank you.
Mr. Chairman, Doug Gray, on behalf of the Virginia Association of Health Plans, there are 675 prescribers in the PMP who don't participate in Medicaid. That's a pretty big number. And, if we actually use the data in the PMP, we could actually identify who was filling Medicaid scripts that did not participate in the program. But we're not permitted to do that. In fact, my commercial plans are not permitted to have access to the PMP. So at some point, if we're serious about it, we could get after this. But I really want to commend the senator. This is something that's a long time coming. I think we tried to do this bill 5 or 6 years ago, and then you eventually got it done in 19 with a huge loophole. We really need to close this. I mean, this is a big deal, and there's room for improvement.
All right.
A lot more.
You can take it any way you want, so. But
Mr. Chairman, members
Yes.
of the subcommittee, Nicole Pugar-Lauder, on behalf of Revita Recovery, who operates substance abuse treatment, OTP, down in Southwest Virginia. They've seen a proliferation of online prescribers that are not offering the counseling and are taking their patients away from the proper treatment at the facility. So we fully support this bill. Thank you.
Thank you. Anybody else in favor of the bill? All right, is there anybody in opposition to the bill?
Move to recommend reporting.
Second.
All right. There's a motion and a second to recommend reporting of the bill. Call the roll.
Senator Saslaw. Senator Edwards, Senator Lewis,
Aye, I'm sorry.
Wake up.
Senator Donovan,
Aye.
Senator Suderline, Senator Pillion, Senator Barker,
Aye.
ayes 7, no 0.
All right, that's reported too. So, Senator Chase, you're up next. So,
Good morning.
good morning.
Good morning, Mr. Chair, members of the committee. The bill I'll be presenting to you this morning is Senate Bill 710, pain-capable bill designed as a Child Protection Act. This creates the Pain-Capable Unborn Child Protection Act, which is an act prohibiting an abortion after 20 weeks of gestation unless in reasonable medical judgment the mother has a condition that so complicates her medical condition as to necessitate the abortion to avert her death and to avoid serious risk of substantial and irreversible physical impairment of a major bodily function. When an abortion is not prohibited post 20 weeks gestation, the physician or authorized nurse practitioner is required to terminate the pregnancy in a manner that would provide the unborn child the best opportunity to survive. The bill punishes performance of an abortion in violation of the act as a Class 6 felony. The bill also provides for civil remedies against a physician or authorized nurse practitioner who performs an abortion in violation of the act. Mr. Chairman, members of the committee, this bill prohibits an abortion after 20 weeks of gestation, and what we're talking about here is we're emphasizing that there are actually proven studies that up to 20 weeks, after 20 weeks, it has been confirmed that the baby can actually feel pain. As a mother of 4, I have a real problem with the current policy that we have right now. We have more than 63 million children's lives that have been cut short because of abortion since 1973. Individuals have the right to life, and as lawmakers, it is our job to protect that, and as doctors, to do no harm. The legislation is a key component of the governor's policy priorities, and he will fight to protect the defenseless. Pain receptors develop in the skin between 10 and 17 weeks gestational age, with the first sensory receptors in the skin formed and connected to the spinal cord at 6 weeks gestation. It is our duty to protect the right to life, and this legislation prohibits an abortion after 20 weeks gestation unless the mother, as we mentioned earlier, has a condition that complicates her medical condition and necessitates the abortion to avert her death. With that, Mr. Chairman, I am happy to answer any questions of the committee.
All right, any questions from members of the subcommittee? Yeah. Senator Lewis.
Chase, I can certainly understand what you're trying to do, but wasn't that almost identical law just struck down by the Fourth Circuit Court of Appeals of North Carolina law?
I am not aware of that particular decision. I'm not really keeping up with North Carolina law, to be honest with you. I've been focused on Virginia. Yes, absolutely. I think regardless of what other states are doing, I think this is a good common sense measure that protects Virginia's children. I think it is reasonable. We're talking about 20 weeks here, which is halfway through a pregnancy. There is no reason. As a mother of 4, I can tell you know when you're pregnant, and at 20 months, 20 weeks gestation, I think that we need to also respect the unborn as well.
All right. We'll take public testimony now. 5 minutes on each side, so they'll come forward if you're...
Maybe you want to switch chairs.
Yes.
Yeah, total of 5 minutes for those who are in support, and then we'll have 5 minutes for those who are in opposition. So,
Hi, good morning, members of the subcommittee. My name is Julia Sabanowitz. I represent the Virginia Catholic Conference. We believe that abortion is a direct attack on the dignity of human person, which promotes and encourages the devaluation and dispensability of life. While there are divergent views on the practice of abortion, it's widely recognized in public opinion polls that a strong majority of the public is consistently opposed to late-term abortions. A Marist poll that was conducted last month in January of 2022 showed that 73% of Americans, including 63% of Americans who identify as pro-choice, support prohibiting abortions after the unborn baby can feel pain by 20 weeks from fertilization. We believe this act recognizes the intrinsic value of the unborn, protects children in the womb who can feel pain. Abortion performed in the second half of pregnancy usually involve brutally dismembering a defenseless unborn child while also posing serious dangers to his or her mother. The bill would prevent these harmful abortions to children who scientifically have been proven to known to feel pain, and we ask you to support Senator Chase's bill. Thank you.
All right, thank you. Next.
Eddie Ayla, Virginia Assembly of Independent Baptists, and we support this bill for the reasons given and believe it closely aligns with the Roe v. Wade decision.
Mr. Chairman, members of the subcommittee, Todd Gackey on behalf of the Family Foundation, also as a father of four and who's also adopted a child, we strongly support this legislation. Thank you.
Thank you. Next.
Hi. My name is Jessica Gertz. I'm 34 years old. I'm a physician and mother of two. And I'm going to be talking to you about my experience about having an abortion at 21 weeks gestation. The weather at the Jersey Shore for Labor Day 2020 was fantastic for everyone lucky enough to be there. I tossed a football in the surf with my sister-in-law as my 2.5-year-old son made sandcastles, his favorite thing to do. I was 20 weeks pregnant. The next day, I took pictures of my son before he headed off to his first day of school. Then I hurried to the hospital for my 20-week ultrasound. Even though I was low risk, I had chosen to get every available standard genetic test. Everything had been normal. My son's gestation and delivery had been completely uneventful. I was 33, fit, no medical problems. I was actually 21 weeks pregnant that day. Due to the holiday, my husband's surgical schedule was a few days later than I had hoped, but I had no reason to expect anything other than a clean bill of health. As a sonographer scanned, my husband and I chatted, unconcerned. The exam seemed to be taking a bit longer than it had for my son, but I didn't think anything of it. As an emergency physician who does ultrasounds every time I'm at work, I know some exams are more difficult than others. The sonographer politely excused herself, said she was going to go grab the doctor to come say hi. My husband and I waited for what seemed to be a long time. We chuckled about having to wait for so long, given that we are both employees of the hospital. Finally, the doctor came in. He shook our hands and started to explain that some of the measurements were abnormal. We sat there, stunned. The genetic counselor came in and I flatly asked her how often she sees these things on ultrasound and the baby ended up being healthy. She said never. She said the odds were 0. We knew at that moment what we wanted to do. I chose to have an abortion. Having been present during a few stillbirths, it remains one of the most terrifying things I've ever witnessed. The thought of watching someone struggle for life and having to watch them die was overwhelming. I also desperately wanted another child. The quicker that I could begin to heal, the quicker that I could have another healthy baby, or I could have a healthy baby. But most of all, I thought of my son. I didn't want to risk my life to go through a traumatic delivery when I knew there was something safer. Whatever I could do to get home to my son, I was going to do. What could I do to miss the fewest bedtimes? When I awoke in the postoperative area, I was overwhelmed by a sense of gratitude for my husband and son, who I could go home to, for my medical team who took care of me with compassion and grace, for my health and the opportunity to take care of patients myself, for being one step closer to having a baby. 3 months later, we conceived a little girl, and less than a year after I sat there stunned in the exam room, I was able to hold my baby girl in my arms. I was able to make that life or death decision in one of the most difficult times of my life. I did not want to risk my life to go through a potentially dramatic labor and delivery. I did not want to tell my son and everyone else in my life why I wouldn't be coming home with a baby after clearly being pregnant. I wanted a baby and I wanted to move forward, and I urge you senators to vote against this bill that would have made my experience and all of the people who have stories just like mine so much more difficult. Thank you for your time.
Can I ask a question?
Senator
No,
Lewis.
it's Senator Chase.
Okay.
I get what the point you're trying to make here. Clearly I do. How do you answer that? How do you answer?
Here's how you answer that question. And my heart goes out to this mother. I also was faced with the same situation. I have personally had to go through 2 miscarriages. It's very painful. As a mother, we are naturally, we want life. I have dealt with many women who have had abortions and have had psychological and mental stress and anguish over the regrets of having that abortion. I've sat before an obstetrician who told me that I had no choice but to have a DNC. And I'm sure that we have a good doctor in this room right now that can probably speak to many of these examples. It is a decision that doctors have to make with their patients, but we should intentionally protect the life. We should never use abortion as a birth control method.
Shouldn't that be her decision? Shouldn't that be her decision to make? And not ours.
And I'm going to defer probably to Senator Donovan on this, but I would tell you as many health and well-being checks as we do, as the doctors do whenever they are making those well baby visits, it's the whole point of that is to confirm pregnancy, and throughout that process, we protect the life. This is all about protecting life.
I'm happy to talk about this now, but I'm also happy to wait until everybody's had a chance to speak.
Go through the rest of it.
My understanding is, Mr. Chairman, that this is supposed to be the time for the period of people who are supporting the bill, or are we now on?
Any others in support of the bill? You haven't testified. Okay, that's why those who are opposed. So.
Hi, good morning. My name is Dr. Shanti Ramesh. I'm an OBGYN and abortion care provider. I'm also the Chief Medical Officer at the Virginia League for Planned Parenthood. I'm here today as an expert in abortion care and to advocate on behalf of my patients. No 2 of my patients are the same. Many of my patients find out they're pregnant very early in pregnancy. I have some patients that find out they're pregnant later in pregnancy. Sometimes my patients know that they want an abortion early in pregnancy and seek many barriers accessing that care. Child care to get to their appointment, time off of work. I have some patients who have very irregular periods. They may go 3-5 months without a period before they find out that they're pregnant. What's important to keep in mind is that these patients are making private medical decisions with their families, their loved ones, and a trusted medical provider like me. I encourage you to vote against this bill in order to keep those decisions between the patients and their provider in the exam room. Thank you.
Thank you. We have about a minute and a half left for testimony here. So.
Keep it speedy. My name is Tara Gibson. Good morning, Mr. Chair and members of the subcommittee. I'm here on behalf of the Latina Institute for Reproductive Justice, and we strongly oppose this bill.
Good morning, Senators, Mr. Chairman. My name is Tarina Keene. I am with Pro-Choice Virginia, and I'm here representing the 12 organizations of the Virginia Reproductive Equity Alliance. We oppose this bill. Virginians deeply value their privacy and their autonomy in making personal medical decisions that are best for themselves and their families. And SB 710 is a clear violation of those values because it inserts politicians right in the middle of their medical providers' offices and the family's kitchen table. SB 710 strikes at the heart of that doctor-patient relationship, which is based on trust, and that is why we all value our relationships with our doctors. Every OBGYN will tell you that every pregnancy is different, and they cannot practice a one-size-fits-all approach to healthcare. They evaluate and treat each of us uniquely. Taking that ability away from infringes on a doctor's medical expertise and replaces it with a government mandate that disregards unique situations. I have a whole lot more to say, but I will also say that I am a mother, and 6 out of 10 women who have abortions are already mothers.
Right.
Thank you.
All right, thank you. Next.
Mr. Chairman, members of the subcommittee, I'm here on behalf of ACOG Virginia, and I'm not going to repeat everything that everybody else said. I just want to focus on the administrative and criminal penalties against an OBGYN in this bill. Sorry, thank you. Line 71 through 72 state that a physician can be found guilty of unprofessional conduct if they first don't determine probable post-fertilization age. I would just say there's certainly times when a patient provides a physician with either inaccurate information, either maybe not purposely, but but it's there, and that leads to an inaccurate estimate of the gestational age that can only be corrected as the pregnancy progresses. A physician should not be found guilty of unprofessional conduct for the patient providing inaccurate information. Line 61 through 63 create a criminal penalty for anyone, including a physician, that a court decides was not using her best medical judgment and performs a procedure, an abortion, that the physician deems is the best interest of the patient. Decisions about what's in the best interest of the patient should be left to the physician and the patient, and the state should not criminalize a decision that is so subjective and individual. ACOG believes that every physician in consultation with her patient should have the ability to make the right medical decision for her patient on a case-by-case basis, and I'll leave it at that. The only thing that I'll also add is just from a personal experience, as you can all see right now. While my doctor and my hospital tried to make sure that I get my scans at the appropriate time and the duration of my pregnancy, it doesn't always happen. I mean, in the real world, if I'm supposed to get it at 34 weeks, perhaps I get it at 35 and a day. So those are the types of things that this bill would impact in a real world situation.
Who are you with?
ACOG, OBGYNs.
College of
Obstetricians and
okay,
gynecologists.
thank you,
Yes,
thank you.
sorry.
All right, thank you. All right.
Mr. Chairman.
Move the bill be passed by.
Mr. Chair, I'd like a moment to speak.
Thank you.
Would you like to go first?
If you don't mind, if I could just conclude very quickly.
Quickly, because we got several.
I'm thinking a number of the people that are behind me did not read the bill. The bill specifically covers issues with the life or death or risk issues associated with a mother. So I want to make sure we understand. And these examples, we're talking about a mother that's at risk or having issues. So that bill covers issues with life or death or serious risk to the mother. Thank you.
Thank you. Senator Sasson, then Senator Donovan. So.
No.
Okay, Senator Donovan.
Thank you, Mr. Chairman. I'd like to speak to the bill.
Sure.
I really am grateful for the opportunity to have an intellectual conversation about this, because as I hear people testify, and as we've talked about this so many times, there is a confusing conversation about elective abortion. And all abortion is characterized in these conversations as life and death and terrible anomalies of the mother. And as a result, that conflation of the actual circumstances has made us incapable of having an intellectual conversation. I will tell you, first of all, this bill says post-fertilization 20 weeks, which is 22 weeks of gestational age, and would not have affected that mother who came forward and doctor. Very much more circumspectly than the United States of America, Europe, who is often touted as having advantages in how they manage medicine that are superior to ours, limits elective abortion to 12 weeks. There's a big difference between a mother that has a crisis with a pregnancy and somebody who is electively aborting because they got pregnant unintentionally. And there are parameters that we can put on law that show respect for those differences and respect for viability. I will tell you, in medicine, a birth that happens before viability is called an abortion. A birth that happens after viability is not. A delivery of a pregnancy after viability is a delivery, and it's either a live delivery or not, but it is not an abortion. And it is time that we put a little bit of sense. I personally, at the start of session last year, delivered a baby at 23 weeks gestational age that had no interventions because of how unexpected the delivery was. Usually we give medications to improve the health of their lungs, to decrease the risk of brain trauma during delivery. This baby had nothing. That baby went home 12 weeks later, perfect, celebrated his first birthday, and he is absolutely perfect. There is a point in time in a pregnancy where a baby can survive, and we should not be allowing elective abortions after that time. And I will tell you also, if you talk to the subject matter experts on timing of ultrasounds and determination of fetal anomalies, there is no reason that every mother would not know by 20 weeks gestational age if that baby had a catastrophic anomaly. And I would also suggest that were there reasonable and sensible limits put on this timetable, as are proposed here, that you can be certain that those ultrasounds would be done at a gestational age so that everybody knew early enough if there was a problem. This is not a radical bill. This is what we have been doing in conflating this conversation about elective and medical. That is really unconscionable. And so I have a substitute motion, and that is that we recommend to report this bill.
Substitute motion.
Okay.
You already had a motion. Mine's the substitute.
Well, actually, we didn't, his had not been seconded. It's because we were just went back to discussion, so.
I withdraw my motion.
All right. All right, the bill is before us. Senator Sasslaw has made a motion. Is there a second?
Substitute motion, since I withdrew mine.
Okay.
I recommend we report.
All right. And there's a second, okay. Motion and a second to recommend reporting. Call the roll, please.
Senator Sasslaw?
No.
Senator Newman? Senator Edwards?
No.
Senator Lewis?
No.
Senator Dunavant?
Yes.
Senator Suderline?
Yes.
Senator Pillion?
Yes, by proxy.
Senator Barker?
No.
Ayes 4, noes 4.
All right, well, we will go to the full committee.
So there's no recommendation.
So there's no recommendation right now, so, yes, that's correct. So, all right.
Thank you. I'm assuming you want my next bill.
Not necessarily.
Senate
but,
Bill 601. Would you like me to speak on the next bill?
I don't know, I'd like you to speak, but.
You know I'm going to.
Yeah.
Mr. Chairman, members of the committee, the next bill that I'll be presenting is Senate Bill 601, which is a bill which prohibits discrimination based on vaccines or recovery status. And what I have before you and would like to pass out to members of the committee is a letter to Secretary Austin, who's Secretary of the Department of Defense. This letter is from Ranking Member of the Permanent Subcommittee on Investigations, Representative Ron Johnson, and I would like to have someone to pass that out at this time, please. Mr. Chairman, members of the committee, Senate Bill 601 is a bill that prohibits the State Health Commissioner and the Board of Health, the Board of Behavioral Health and Developmental Services, the Department of Health Professions, and any regulatory board therein, and the Department of Social Services from requiring any person, including any child, to undergo vaccination for COVID-19 and prohibits discrimination based on a person's COVID-19 vaccination status. Number one, with regard to education, employment, or issuance of a driver's license or other state identification, or in numerous other contexts. Mr. Chairman, members of the committee, I've never seen, and none of us have ever seen in our lifetime, a situation where we have people, Virginians, who have made a conscientious decision not to get a vaccine and yet be discriminated against. They have to choose between a jab or a job, getting an education, not getting an education, getting a transplant or not getting a transplant, and be taking off a critical life-saving list. But yes, that is what is happening. Why are we forcing Virginians to get a vaccine against their will? You know, we have just in Virginia allowed marijuana to be legalized, and we are forcing Virginians to get a vaccine which has been, whether we agree with it or not, has been around for less than a year, and yet we have seen evidence, as I presented to this committee and other bills, the use of alternative treatments, monoclonal antibodies, ivermectin, hydroxychloroquine is also an alternative that keeps people out of the hospital and has been proven to work. There are alternatives when people get COVID, even taking ivermectin prophylactically. Why are we forcing Virginians to get a vaccine against their will? Virginians are being forced to choose between getting a jab and keeping their job or losing everything. And there was a Gallup poll, July 20th through August 2nd of 2021, a Gallup poll that shows more than a third of Americans, or 1 in 3, would refuse a free FDA-approved vaccine, even if it was readily available. Asked if they would get such a COVID-19 vaccine, 65% said they would, but 35% said they would not. So why are we forcing Virginians through forced coercion to get a vaccine against their will? It should be a person's right. January 2022, the Supreme Court ruled against OSHA, larger employer vaccine mandate. They did uphold the mandate for the healthcare workers, which I disagree with. But in just 2 issued decisions, the NFIB versus the Department of Labor and Biden versus Missouri, the Supreme Court ruled against OSHA COVID mandate for workers employed by large employers of over 100 employees. What I have before you, Mr. Chairman, members of the committee, is a letter that actually outlines a number of issues that people like myself and others in this room have educated them so that with based on the data from the Defense Medical Epidemiology Database. It's reported that there were increases in registered diagnoses in 2020 for the following medical conditions: hypertension, 281% increase; diseases of the nervous system, 1,048%; malignant neoplasms of the esophagus, 894% increase; multiple sclerosis, 680% increase; malignant neoplasms of digestive organs, 624%; breast cancer, 487% increase, and I think we all get the idea. 300% increase in cancer, 1,000% increase in neurological disorders. Mr. Chairman, all I'm simply saying here is that it is a person's choice whether they get the vaccine or not. And we as Virginians and as legislators, we should not be in a situation where we are mandating what is considered an experimental vaccine. We should allow Virginians to educate themselves and make that decision for themselves and not be at risk of losing their job, being denied getting a transplant, or being denied an education. And I have a number of speakers here today. One who is, her husband is actually in intensive care and is actually on a ventilator in the hospital. And I think her testimony is very compelling. They're even risking, if he does not get the vaccine, that they're going to take him off the transplant list. So I appreciate your patience in listening to these very passionate Virginians.
All right, any questions from members of the committee? All right.
Yeah,
Yes, yes, Senator Sasslaw.
You do understand that one of the reasons that you see this is that the feeling of a lot of employers is that your refusal to get that vaccination, they should not have to tolerate you putting their other employees at risk. We require certain vaccinations for kids to go to school. In California, you can't even go to a private school as a youngster unless you've been totally vaccinated. And I suppose in your world, you shouldn't have required anybody to get the Salk vaccine either.
Mr. Chairman, and to answer the gentleman, if the vaccine is so effective, then why is it that it's still vaccinated people are still transmitting the virus to other people?
It doesn't stop the transmission. It stops the seriousness of the illness.
But it's not. It's not. And there are many situations of people.
Hold on. Mr. Chairman, let me just say this. 98% of the people at Inova who are hospitalized, okay, unvaccinated. 98% at the largest hospital system in the state.
Mr. Chairman.
Mr. Chairman, I think that I think we've exhausted questions about the bill itself.
Yeah.
And I think that it's time for public testimony. And I hope that you'll tell folks how long you'd like each side to speak for.
Yeah, let's do.
So that they know.
Do the same as we did on the other one, with a maximum of 5 minutes for each side to present. So
I don't know who's speaking in support of this bill, but please understand we have a total of 5 minutes.
Right. Okay.
How many other speakers do we have coming up to speak in favor of the bill? I know we had. Do we have anybody in the hallway?
I don't know. Okay, go ahead, ma'am.
Okay, my name is Bonnie Stewart. My husband, Jim Stewart, contracted COVID-19 on September 2nd, and he's currently now at UVA Medical Center still fighting. So he's in the ICU. And we had a meeting with a doctor there at UVA 2 weeks ago that asked, that said that he could be possibly put on a transplant list, but that his immunizations on his MyChart needed to be updated. And that meant that he needed to get his vaccine and his flu shot. He's lost 50 pounds. He's currently has a sacrum wound to the bone from the effects of COVID on his body. He had COVID pneumonia. It ravaged his lungs, and he has 50% of his lung capacity now. So he's 56 years old. He served in our Navy. He's a very healthy man, and all of his other organs are fine. Right now, the doctor said that to have any normal life, that a transplant would be a good an option for him, and so what he told me was that if he didn't get the vaccine, that he would not be put on a transplant list. And so right now his body is so compromised that I've read everything about vaccines, and for my husband right now that is not an option. He would not even make it, so he would not even be on a list for lung transplant if he got a vaccine. And I've had 5 doctors attest to that at this stage of his care and his health. It's just not feasible for him. And I believe that it's a choice of each American in this country, whether or not there's so much risk of vaccine shedding from people that I've read about, that and I've been told by doctors that if you do get the vaccine, you're not immune from shedding part of that vaccine and infecting another person with COVID either. So there's still so many things we don't know about this vaccine. And when I'm looking in the eyes of my husband, and I want the best for him and a quality of life, I think that he has a right to get on a transplant list. And that's what I would like to present here today, respectfully.
All right. Thank you. Are there others who wish to speak in favor of the bill? All right. Are there those who wish to speak in opposition to the bill? All right. The bill is before us. Yes, Senator Sassow.
I move that it be passed by, that we recommend that it be passed by indefinitely.
Second.
All right, a motion and a second to pass it by indefinitely. If there's no further discussion, call the roll.
Senator Sasslaw?
Aye.
Senator Newman? Senator Edwards?
Aye.
Senator Lewis?
Aye.
Senator Dunavant? Senator Suderline?
No. Senator Donovan cast no vote.
Oh, okay. Senator Suderline?
I vote no.
Senator Pillion?
He votes no.
Senator Barker?
Aye.
Ayes 4, noes 3, 1 abstention.
Donovan doesn't abstain. She is
Oh.
no vote at all.
All right.
Thank you.
All right,
Thanks for
thank you. So we'll take that recommendation to the full committee then. So, all right. I think we're down to bills of members. Senator Suderline.
All right.
Thank you, Mr. Chairman. I've got Senate Bill 511. It deals with opioid treatment programs, pharmacies, and who can perform the duty of dispensing those. I have a line amendment that I believe council has.
All right.
And briefly explaining the line amendment. So what the the bill seeks to do is allow, thank you, is to allow nurses to perform the same duties that we allow pharmacy techs to perform in dispensing this medication, and the amendment seeks to clarify that would include both registered nurses and licensed practical nurses.
Right.
And so I move the amendment, and
All right, is there a
Senator
second?
Pillion seconds it.
Pillion seconds, okay. All right, we have a motion and a second to adopt the line amendments. All in favor say aye.
Aye.
All right, all opposed, no. All right, those are adopted.
Thank you, Mr. Chairman. And so the bill's pretty straightforward. We've got someone here that would like to explain why they support the bill. I think, yep, there she is.
One more time. Nicole. Mr. Chairman, members of the subcommittee, Nicole Pugarlatter, on behalf of a number of outpatient treatment facility providers, substance abuse outpatient providers. And yes, thank you to Senator Suderline, first of all, for introducing the bill on their behalf. And as he explained, really what it does, it just allows a nurse, now with the amendment, to do the work of a pharmacy technician. I'll share with you that this was permitted under the Board of Pharmacy, rules that were relaxed during COVID-19. So we're technically just perpetuating what had been practiced during the epidemic. I can go into detail, but if you have any questions, I'm also here to answer those questions.
All right, are there any? Yes, Senator
Mr. Chairman,
Suderline.
I have not met anyone in opposition to this bill, although yesterday I sat right there and had a bill that hadn't met anyone, and two people came up, so maybe I'll meet new friends today.
Yes. Yes, Senator Edwards.
Is this the right to poor bill?
Yes, that is correct, sir. Yes.
It's a great name for it.
Yeah, that's a great name.
Yeah. All right. Anybody else wishes to speak? Okay. All right, it's been moved and seconded that the bill be recommended for reporting. If there's no further discussion, we'll have the call the roll.
Senator Saslaw. Senator Newman. Senator Edwards. Senator Lewis.
Aye.
Senator Dunavant.
Yes, by proxy.
Senator Suderline.
Yes.
Senator Pillion.
Yes, by proxy.
Senator Barker.
Aye.
Ayes 8, noes 0.
All right, we will recommend reporting that bill to the full committee there. We have 3 bills from Senator Donovan, but she's not here right now, so we have Senator DeSteph. So.
Good morning, Mr. Chair, members of the committee. So with Senate Bill 676, this kind of takes a unique approach. And let me give you a little bit of what's going on. So a few years ago, we had a shortage of doctors, which I believe we still have a shortage of doctors. So we've expanded our medical schools. We spent a lot of time in the General Assembly doing that. Working with groups, we've put a lot of money into helping offset the cost of doctors getting through medical school. We've put grants in place. We've put a ton, when I say a ton, I mean tens of millions of dollars into foundations for doctors to get through medical school and help pay for medical school. And we've done a fantastic job with that. What's happened on the other side, and today we have over 10,000 doctors who've finished med school, have passed, I believe it's called phase 1 and 2, step 1 and 2 of their boards. Some of them have passed step 3, but there's no residencies. So we expanded the capability and capacity to have more doctors. We're in the middle of a pandemic, and we have all these folks who've gotten through med school, gotten through step 1 and 2 of their boards, and some through step 3, and we have over 10,000 of these individuals waiting for a residency. So there's no residencies available. They're all full. So I understand at the state level that we can just push on the federal government to expand the number of residencies. We can work with our university hospitals to expand our residencies. But there's a limit on them, and it's not been addressed at the federal level, so we can further address it at the state level. So what I wanted to do was start the conversation with similar to what Missouri did, and let me back up a step. During a pandemic, these folks who've gone through medical school, step 1, step 2, and some of them with step 3 of their medical boards, they can't even give a shot. They can't even write a prescription, but they cannot even give a shot. Yet nurses, we've eliminated a lot of what they have to do, and they can actually give shots and start right into nursing. What Missouri did is they've called them associate physicians. And again, I don't want us to pass this bill today. I want us to study this process and look at how best to address it. Missouri did a good job with their associate physicians, I thought. I don't believe Virginia is ready to do that without studying it. So what I'm hoping is that when the full committee sees this, they'll carry it over for a year with a letter from the chair, and they'll study how do we handle this in the state of Virginia. I've got a couple of letters from myself to Dr. Northam talking about this, Governor Northam, when he was in there, dated, the first one was in July, the second one was in December. I have one January 31st to Governor Youngkin. I have one January 15th to Governor Youngkin. And we've got a group of our doctors who are also teaching at EVMS. One of them teaches down at Duke. He's like, guys, we've got to address this. We've got to figure it out. So I threw up what Missouri had done, thinking, hey, it's a start to start a conversation, knowing that there's going to be a lot of doctors groups against it and a lot of people against it, but to start the conversation, because these folks have literally gone through medical school completely, phase 1, 2, and 3, and they're waiting on the boards.
I may have missed this. Who do you want to study this?
I'm not sure who actually studies this. Again, I know that somebody in the somebody on the committee will know.
He's in the room.
There you go. Perfect. There we go.
Board of Health Professions. So
perfect. Again, all I want to do is we have in Virginia alone, we have over 1,000 folks who've passed their boards, right. Phase step 1, 2, and some step 3 of their boards, and there's no residency for them.
Does your bill designate a study?
No, sir. My bill actually just duplicates what was done in Missouri. Yeah. So I was just hoping we could.
What he's asking is that we don't report the bill, but we
continue it till next year and kick it off and from the chair saying, hey guys, look at this problem and let's address it, get it fixed. We can certainly do a substitute. I'm happy to do a substitute, work with the attorneys and do a study for this.
George,
yes.
Motion, if it's okay, that we carry the bill over for the year and ask the chair to send a letter to the Board of Health Professions to review the matter.
All right, there's a motion. Is there a second for that?
I'll second that.
All right, Dr. Brown, we did have this bill a few years ago from a delegate, Stolle, I think was the last name, but he.
I think I killed it then, too.
Sibling rivalry, but was there any involvement from the Board of Health Professions at that time?
You know, I don't think the Board of Health Professions, I can't remember if the agency was asked to do the study or not. But I will say there's one difference in this bill and what was proposed by Delegate Stolle is that this bill allows licensure for 2 years. And I don't think there was a time limit in the previous bill. So there is a little bit of a difference here. And we would be delighted to study it. I might recommend that it be referred to the department rather than the Board of Health Professions. It might be a more efficient way of managing that.
I adjust my motion to
that. All right. We have a motion that the bill be recommended for carryover with a request to the chair of the committee, Senator Lucas, to send a letter to the Department of Health Professions for evaluation of this. So, if there's no other discussion and no one else to testify, then call the roll on the motion.
Senator Saslaw.
Aye.
Senator Newman. Senator Edwards.
Aye.
Senator Lewis.
Aye.
Senator Dunavant.
Aye.
Senator Suderline. Senator Pillion.
Yes, by proxy.
Senator Barker.
Aye.
Ayes 8, noes 0.
Ayes 8, no 0.
Mr. Chair, members of the committee, thank you very much.
Thank you. All right.
May I stay here, Mr. Chairman?
Yes, you may stay here, and so would Delegate Stiley's sister proceed, so.
Thank you, Mr. Chairman. I'll start with 671, which is about our pharmaceutical processors. These are the medical pharmacies that are vertically integrated, and it's really just, we just have an ongoing need to kind of update process, and that's what this is about. And this bill is similar to Senator Marsden's, but a little bit different. It does remove the patient from having to register with the Board of Pharmacy, and that's really important because it is an obstacle. It directs the Board of Pharmacy, as his does, with to instead of Supreme Court to issue the certifications. Let's see. I think that it just has a few more literally things about clarifying advertising regulations, establishing product deviation standards, reducing costs of green waste destruction, just process changes to make it more efficient. There's nothing worrisome or difficult in this bill at all, but it is a little bit different from Senator Marsden because it includes some of those additional pieces of language, and he did not want to roll in. I'm happy to have people speak to it. Hopefully, I think Hunter's still downstairs, but if you have any questions, I'm happy to see if I can answer them. Probably not, but I'll try.
I understand that there's differences between your bill and Senator Marsden's. Is there anything that's in conflict between the two bills?
No, sir. No.
Okay.
In fact, Senator Marsden's and counsel. Oh, I have a substitute. Thank you so much,
the
dear.
substitute.
What would I do without counsel?
All right.
And with his substitute, his is now aligned to the same language as mine for the parts of his that are similar to mine.
All right. Thank you. All right, we have a motion to adopt the substitute. All in favor, say aye.
Aye.
All
And
opposed, no. Okay, the substitute's adopted.
This
So-
substitute is really a matter of conversations between Board of Pharmacy, Department of Health Professions, the processors, just to make sure we could get peace in the valley and get everybody on the same page.
All right. Are there any questions of the patron? All right. Is there anybody to speak in favor of?
Oh, Hunter came back.
He heard you.
Yes.
So.
The other Hunter's downstairs.
Yeah.
Good morning, Mr. Chairman, members of the subcommittee. Hunter Jamerson on behalf of JUSHI. Very much appreciate Dr. Donovan bringing this bill, which is long and complicated, but does a lot of really important things. It's partially long because you've already recommended reporting Senator Marsden's bill, which deals with the patient registry. I won't belabor that point, but all of those points are incorporated here identically and are very important. I'd like to thank Dr. Brown and Caroline Jura and the Board of Pharmacy, who spent significant time with the board to make sure this bill is technically implementable. But as Dr. Donovan has explained, this will improve patient access. This will lower prescription costs for medical cannabis. We ask that you recommend reporting this bill. Thank you.
All right. Yes.
Good morning, Mr. Chair, members of the committee. Cassidy Crockett-Burba on behalf of the National Organization for the Reform of Marijuana Laws. We support the bill and thank Senator Donovan for her continued advocacy on behalf of Virginia medical cannabis patients. Thank you.
Thank you.
Good morning again, Mr. Chair. Randy Pearson on behalf of Columbia Care, the licensed medical cannabis processor in HSA 5, the Hampton Roads region. We support the bill and thanks Senator Donovan for bringing it forward.
Thank you.
Missy Wazlowski with Greenleaf Medical. I'm just going to say same as they all said.
All right. Thank you. Is there anyone in opposition to the bill wish to testify?
Mr. Chairman.
All right. Yes,
I
Senator Edwards.
haven't researched the substitute, but I was advised that the Board of Medicine, Board of Pharmacy, Department of Health, and experts, they couldn't reach a consensus on this, and the Medical Society was against the bill. Is that wrong?
No, that's a different bill that she will be
Oh.
presenting in a moment, I think. so.
Okay.
But thanks for the heads up.
Ahead of her, so.
Okay, all right.
Wanted to send a warning on what's coming next.
671, I see. This is
All right.
672, okay.
Thank you. All right, any further comments or discussion? All right. Yes.
We spent last year and this year, we spent probably about 500-600 hours on this topic, and if we legalized moonshine instead, we'd have been done with it.
All right. Is it, the bill's before us now. Is there anybody want to make a motion?
Move to report. Recommend reporting.
All right, there's a motion and a second to recommend reporting. If there's no further discussion, we'll call the roll.
Senator Saslaw.
Aye.
Senator Newman. Senator Edwards.
Aye.
Senator Lewis.
Aye.
Senator Genevant.
Aye.
Senator Suderline.
Yes.
Senator Pillion.
Yes by proxy.
Senator Barker.
Aye.
Ayes 8, noes 0.
All right, we will recommend reporting the bill to the full committee. All right, next.
Thank you, Mr. Chairman. The next bill is Senate Bill 672. This is a follow-up from a bill that we looked at and passed in a form about 2 years ago, and it's dealing with pharmacists being able to implement interventions in the pharmacy that traditionally they have not done but are within their scope, and we've really had a demonstration in the last year how valuable their accessibility has been in our issue to address COVID. This bill does a few things. It allows the pharmacists to work through telehealth, which, by the way, we're already doing in our medical marijuana pharmacies. It also allows them, we've revisited the issue of some scope issues like nicotine replacement and tobacco cessation therapies. They can initiate. I will remind you, as we talked about this before, pharmacists do not prescribe. They do not diagnose, but they do initiate and they do dispense. And so when we look at a bill like this, it's predicated on the idea that there's a collaborative agreement, and collaborative agreements have existed for a long time in medicine, and they are where physicians and pharmacists agree on an algorithm of how they will proceed in a disease state based on information that's collected as you go along. So, for instance, there are collaborative agreements on blood pressure, where if a patient comes in and their blood pressure is a certain number, that adjustments can be made by the pharmacist for increasing the medication so that the patient has a better outcome and therapy.
I've had a request here. Can you give an example of sort of how this would work practically with a
As
condition?
opposed to what we have now.
For nicotine?
For whatever.
What your bill would accomplish.
All right, so what it would do is it would allow pharmacists to initiate nicotine therapy, and they would allow them to do tests, which would include a strep throat or strep A bacteria, influenza, urinary tract infection, and initiate those treatments and prescriptions based on the protocols that are pre-existently agreed to by the Board of Medicine and Board of Pharmacy. They would be able to vaccinate children within the normal scope of pediatric vaccines.
So in other words, you could come in and go through this without seeing an MD.
Correct. But there would be very stringent protocols that were associated with that that would allow to ensure that the exceptions to an infection like this, which is most of the time very simple, that the patient has very clear information about when they should seek an appointment with the physician, and also encourage primary care contact. So it would be the pharmacist saying, do you have a primary care doctor? Can we connect you with one? So it's really a way to kind of wrap around services, but but allow pharmacy, they're open on the weekends, they're open at nights. And so this
It's worked well with the COVID shots.
It's worked really well with COVID testing and COVID shots. Yes. So yes, I mean, essentially This is an ongoing project. I won't kid you. There are a lot of people talking about this. There's some amendments I have. It's probably a full substitute. There will probably be more before full committee as we build consensus, but we're on a really good path now. This was a little disruptive for pediatricians and for some of the physicians, but we are figuring that all out and making sure that we accommodate their concerns and build the best darn box we can build.
All right, are there questions of the patron?
Do you need to move the substitute?
Yes.
All right.
I'll move the substitute.
Second.
All right, motion has been made. There's a second to adopt the substitute. All in favor say aye.
Aye.
All opposed, no. All right, the substitute is before us, so.
I'll move it to be reported.
No, there's a little testimony that's going to be coming on this one, so. All right, let's start out with those in favor of the bill. Wishes to testify in support.
Good morning, Mr. Chair, members of the committee. I'm Christina Borelli with the Virginia Pharmacists Association. We'd like to thank Senator Donovan to continue to bring this bill before this committee. We know that this issue is not new to any of you. We've been working on it for 3 years now. We've had a number of work groups that have met. Consensus has not been easy, has not been happening, obviously, because we have equal representation between the two professions on most of our work groups. So I know that that might be a concern for the group. But what we have seen over the last 2 years is that patients need convenient access to care. This is not meant to undermine anyone else's relationship with a provider. It's simply to allow another access point to patients. So if it is Saturday morning at 8 a.m. and you start feeling like you're having UTI symptoms, you don't wait until Monday to have an interaction with a provider to get the necessary medication you need. We have many members, in particular, I was talking with Rayfield Pharmacy on the Eastern Shore, and they said, you know, if we could have this service that patients, when they started feeling ill, that they would not wait to get care, we know that that's going to prevent infection in the long run. Additionally, when we were working on the crisis standards of care last April 2020, one of the things that were determined very valuable is to allow pharmacies to triage patients. So allowing a patient a first stop, and many patients have become very familiar with seeing a pharmacy for care. This is just another access point for them, and we have a couple of doctors that would like to come up and talk to you today with the Virginia Pharmacists Association, so I'm not going to take any more time. Thank you.
Thank you.
I have a question.
From Senator Edwards.
The pharmacy we have in Roanoke has a 1-minute thing.
Oh, the Minute Clinic?
Yeah, and they'll give you some, well, you need to see this, you need to do that, whatever. Why doesn't that cover the issue?
Well, I believe Minute Clinics are staffed by MPs. I don't know if CVS is still in the room, but they can probably speak more to that business model. What this is looking at is, you know, every pharmacy doesn't necessarily have an MP that's staffing it. It has a pharmacist with a PharmD that would be able to meet with a patient, offer a test, do a consult, do an assessment, and then offer the antibiotic upon a positive test.
All right. Any further question? Okay. Next.
Good morning. My name is Dr. Alexis Page. I am a practicing pharmacist, and I would like to ask for your support for this bill. I would like to share that the purpose of this bill is really to increase patient access to care. What was mentioned earlier, pharmacists have shown their dedication to increasing access to care with COVID-19 testing and providing immunizations, and this will just allow patients to have further access points to necessary care, such as providing testing and treating services for flu, strep, and UTIs. I also would like to instill confidence in the education that we receive as pharmacists. Pharmacists are receiving doctorate degrees, so every pharmacist that's coming out of school right now is a doctor of pharmacy. Thank you for your support.
Thank you.
Hi, good morning. Thank you for your time. My name is Dr. Leah Argy. I'm a pharmacist and a pharmacy owner in Charlottesville, Virginia. So I have one store, and we actually have some collaborative practice agreements with a doctor for vaccines, and then we're also working on another one for hormone replacement therapy. And all I can say is these collaborative agreements actually bring us a lot closer to the physicians we're working with. We have more interactions, we have follow-up, and the relationship is even stronger when we have these agreements versus the relationships we have otherwise.
All right, thank you.
Thank you.
Next.
Mr. Chairman, members of the Jody Roth on behalf of the ACDS. We wholeheartedly support Senate Bill 672 to allow patient access to their community pharmacists for all the reasons that were just laid out by the three previous speakers. So I won't trespass too much on your time by repeating what they said, but I think it's been obvious that patients do trust their pharmacists, given over the last 2 years, the 9 million vaccines that our pharmacies have given. Thank you.
Thank you. All right.
Good morning. I'm Dr. Kelly Good. I'm a professor at Virginia Commonwealth University, and I'm also a liaison member to the National Vaccine Advisory Committee. Thank you, Senator Donovan, for introducing a bill that will help modernize the practice of pharmacy as well as provide needed access to preventive treatments and early treatment. I want to address the vaccine piece with 3 and up. Currently, under the PrEP Act, pharmacists are vaccinating in Virginia ages 3 and up, and so this has helped get children into schools so they're not delayed because they don't have their needed vaccines. And it's also preventing having return of vaccine preventable diseases in the Commonwealth of Virginia. It also has meant that we're able to partner. So we're seeing these partnerships emerge in rural Virginia where we don't have access to primary care for patients. So these pharmacists are partnering with the physician providers that they're through referral. And then lastly, when we look at the disruption of the medical home, this will no longer happen because of January 1st, 2022, all healthcare providers who are administering vaccines have to report their doses to the Virginia Immunization Information System, which means that if I'm getting ready to give a vaccine, I can look up and see what vaccines that patient has had, and then I can also I will be reporting my vaccines that I've given. So pharmacists will be required to do that just like any other healthcare provider, so that physicians will know what vaccines they've gotten in the pharmacy, and it'll prevent errors and missed doses. So I think this is a great opportunity to enhance the healthcare team through partnership with pharmacists and physicians. And lastly, the referral piece is key. Pharmacists will be referring and helping get people into primary care that may not be able to access primary care otherwise. Thank you.
Thank you.
Mr. Chairman, just while opposition is lining up, I'll say a couple of things here, that because of the PrEP Act at the federal government level that's allowing pharmacies to do pediatric vaccinations now, there's an enactment clause on here that this would start in Virginia when that goes away. If and when the PrEP Act goes away, we don't need it in Virginia. This does allow technicians under the supervision, and some of the language that's added, maybe not reflected here from MSV, is that the technicians would be supervised under the pharmacist that is in, at the pharmacy at that time. So those are some of the other changes in this substitute.
Chairman, before we get to the opposition, can I just ask just fundamental question so we know how to interpret the opposition? Siobhan, I should have asked you earlier, I apologize, but a couple. One, how is this substitute dramatically different than the underlying bill? In other words, what have you taken out?
Number one, I moved the pediatric vaccination to an enactment clause instead of it being in the body of the language. There's some of the amendments we've accepted that are not in here, like the supervision of the pharmacy tech. Okay. But other than that, there is COVID. I ensured there were some placement issues. COVID testing wasn't under the adult testing. There were some things like that, but there's not a lot I've taken out.
Okay, one quick.
Yes, Senator Newman.
Siobhan, how are they going to get paid? In other words, are they going to get paid for service, or is this going to be paid for a product? Or in other words, how is a pharmacist going to be paid for service?
I believe they can already be reimbursed under the ICD-9 coding, and I can have a pharmacist come forward and let you know. I don't know but they get paid the same way that we do. They just get paid only. There's a vaccination reimbursement fee that is different than an entire visit fee. Is that accurate?
So it's correct. So vaccines would be under they get an administration fee as well as product, just like a physician. And so for the services, for the other pieces of the bill, it would be either the patient would pay or the pharmacist could have a contract with a third-party payer to pay for service.
Senator Newman.
George, let's take strep. How are you going to get paid to determine whether someone has strep? In other words, it can be a schedule. How are we getting paid?
So just like any other healthcare practice, there's a usual and customary charge, right? So if I don't have insurance, this is my usual and customary that I'm going to charge. So those would be posted just like anything else, or the patient would know that up front. If the patient has the opportunity to pay a copay because the pharmacist has a contract with a payer, then it would be the same. So it would be the same process as if they were in a physician's office.
Mr. Chairman, the last thing is tell me about your med-mal and tail and other insurance that would relate to this product. In other words, let's say something happened with strep. I know these aren't the big stuff, right? But I mean, is this under your scope, under med-mal?
It would be covered under liability if it's in the scope of Virginia, right? So if it's not in scope, then we wouldn't be covered if we were doing it. So that's what this bill does, is it expands and modernizes the scope of practice for pharmacy. So then it would be covered.
Thank you, Mr. Chairman.
Thank you. All right, those in opposition.
Morning, Mr. Chairman, members of the committee. Scott Johnson for the Medical Society, and I would describe our opposition as a working drafting opposition as opposed to substance. The leadership of the Medical Society met on last evening and said if we can get the words right, then we probably will be in a good position. And I've talked with Senator Donovan. I've shared some language with her, but she's been on the fly, and I have too since 11 last night, and we just weren't able to get it done. But things that need to be fixed in here is making sure that they refer to telehealth. We use telemedicine as a term, and making sure standard of care is complied with, making sure we got a plan in place that if you treat one of these patients and they have a complication, how that's dealt with, as opposed to saying call 911 and go to an emergency room. So I think that if the committee advances this, you've got our commitment to work with Senator Donovan and y'all between now and the full committee to get the words right. And so with that, I'll be glad to answer any questions.
All right, any questions? All right. Next.
Good morning, Mr. Chair. Lauren Schmidt on behalf of the Virginia chapter of the American Academy of Pediatrics. And we also have been working with Senator Donovan and appreciate a lot of the changes that have been made. And I just want to echo Scott's comments that I think that if we can work a little bit more on it to fine tune some of the language, that the pediatricians will be okay with it. Thank you.
All right, anyone else to speak in opposition?
Georgia.
All right, Senator Newman.
May I ask the patron just one more question? Whatever you call it, whether it's telehealth, telemedicine, would a pharmacist be able to diagnose someone with strep, let's just say, over the phone? Okay, because that's outside the standard of care?
Because it doesn't involve the CLIA test. They have to be able to, they have to do these on-site rapid tests, yeah. And, there's other language in here. I will tell you that patients often have to come to my office to get a Depo-Provera shot, which they have to do every 12 weeks, and they have to pay a copayment, not maybe even more than they would pay if they went to the pharmacy. But it's really inconvenient for those patients, and so being able to make this transition, we do allow that to happen for minors in this bill. Now, the one change we did make, again, for a safety check, is that minors will have to have a prescription, which adults do not have to have in Virginia, and that is past language. That is a bill that has passed before. But for minors, they would have to have an active prescription just to make sure we're getting all that testing and everything else. But again, it's always connecting the patient back. You should see your gynecologist. You should have STD testing. You should, all of those things. So thank you, Mr. Chairman.
All right, any further questions or discussion? All right, we operate on a motion.
To recommend reporting as amended, I understand that Siobhan worked with the Medical Society and others to get the language right.
I'll second.
All right, a motion and a second to recommend reporting, and if there's no further discussion, we'll call the roll.
Senator Saslaw, Senator Newman, Senator Edwards, Senator Lewis,
Aye.
Senator Donovan, Senator Suderline,
Yes.
Senator Pillion,
Yes, by proxy.
Senator Barker.
Yes.
Ayes 8, noes 0.
All right, thank you. That bill will take up in full committee then, I guess, next Thursday. So, You got one more?
Yes, thank you, Mr. Chairman. Last bill is Senate Bill 647, and I think this is going to be easy. Basically, this is a request from VHHA so that we can codify some of the language we created in the vaccination bill that was co-patroned by every senator in the Senate last year. And it really just unleashed the workforce, and it's something that they would rather not have to wait for. God forbid we have need for that workforce again. The big change is in this bill on 19 is that instead of it just being a federal emergency or a state emergency, it gives the board, and we changed this language to make it very, very narrow, but it gives the board at the Department of Health Professions, for the purposes already included in the language, the limited purpose of administering vaccines as an approved countermeasure for such communicable, contagious, and infectious diseases. So the board can make a decision to unleash this outside of a state of emergency. And then down in the bottom in the enactment clause, or in B, it basically lists all the people that we all decided to list last year that could participate in this. And that, Mr. Chairman, is the bill. I have amendments.
Right.
Darn it.
So moved.
Yes.
All right, it's a motion to adopt the amendments. Is there a second?
Second.
All right, if there's no discussion, all in favor say aye.
Aye.
All opposed, no. The amendments are adopted, so.
Oh, yeah, Mr. Chairman, I'm gonna leave this. I'm not gonna forward this amendment. This is an emergency clause that actually the Virginia Department of Health said would be helpful because they really don't know where they are yet. But I think they can add that on as it goes to signature. We don't need to worry about doing it in the Senate, unless you disagree.
My thing is, I don't think this is controversial,
So it's okay.
I think I would
All right,
leave
then
it on. Because
we'll leave the
yeah.
emergency clause on.
All right. So the amendment is adopted.
Thank you.
And is there anyone to speak in favor of the bill? So might you be that mysterious VHHA she referred to? So.
Yes, sir. Brent Rawlings, Virginia Hospital and Healthcare Association. Thank you, Senator Donovan, for helping us with this legislation. She did an excellent job explaining it. Sounds like we're in pretty good shape, so I won't waste any further time. But if you do have any questions, this is just one of those things where in the state of emergency, we were scrambling to get vaccinators in place. You all recognized that when you passed legislation last year. Unfortunately, it expired with the state of emergency, so this just puts it in place for future public health emergencies so we can break the glass if we need to and get those available vaccinators out as quickly as possible.
All right. Thank you.
Mr. Chairman, you may remember that the plan we had was really, the hospitals were the one that did all the vaccination when we first got vaccination, and they really had a lot on them. I mean, it was a big job. And so this was partially to give access not only to locations in the community, but people that could help them because they were taking care of COVID patients and vaccinating with their staff. So I think this is, hopefully we'll never need to use it. If we have it, we won't need it, but now we have it.
Thank you.
So. All right. Anyone else to speak in favor of the bill? Anyone who wants to speak in opposition to the bill? All right. Anyone want to make a motion?
Second.
All right. We got a motion to recommend reporting and a second. If there's no further discussion, call the roll.
Senator Saslaw.
Aye.
Senator Newman. Senator Edwards.
Aye.
Senator Lewis.
Aye.
Senator Donovan. Senator Suderline.
Yes.
Senator Pillion.
Yes, by proxy.
Senator Barker.
Aye.
Ayes 8, no 0.
All right. Thank you all. That concludes the calendar for today, and it concludes all of this subcommittee's actions on the Senate bills. So, thank you. So, yeah.
Yes, thank you, George.
Thank you.
All righty.